So what we have to do is try to subclassify nerve disorders into different categories and just choose the ones that are best suited for neural mobilization. Yeah? Now traditionally we classify nerve problems by a syndrome. So we have carpal tunnel, tarsal tunnel, pronator tunnel, radiculopathy, all these different names, but unfortunately that doesn't really help the treatment because we know there are asymptomatic people with features of radiculopathy, stenosis, carpal tunnel, tarsal tunnel. Yeah? If we treat the condition, it doesn't necessarily make the pathology change and the pain change. Yeah? So instead of thinking about the pathology, we should think about the underlying mechanisms that cause the pain. Yeah? And here's a good example. Here's a patient with a prolapse with leg pain. Yeah? And this is the patient 6 months later and the leg pain had gone. Yeah? Here's a patient with a large prolapse. This is the patient 3 months later and the prolapse had gone. Yeah? But whether the prolapse changes in the back has a very poor correlation with whether your pain changes. So you could have complete resolution and your leg pain is still there. You could have no change and your leg pain is gone. Yeah? Here's some scans a friend of mine sent me. This is a patient he was treating in his clinic for radiculopathy. The patient had severe leg pain, and you can see April to July. You can see that there's a change, there's an increase in the prolapse, but his leg pain had reduced. So I'm not saying that this is not important. Imaging is important, but we must treat the patient and not the scan. Yeah? That's very important. So we must think about the underlying mechanisms. Now, there are many different mechanisms underlying nerve pain. Yeah? And I would broadly classify them into central mechanisms and peripheral mechanisms. The central mechanisms don't seem to respond so well to physical treatments. That's why we need to identify those people. The peripheral mechanisms, and I've put an example of one here, these do tend to respond well to physical treatments, and we can do something to help them. It's very complex. We could spend days just talking about these mechanisms, but that's why I think it's important to understand that we have pain because of these underlying mechanisms, and if we can understand about them, we can then understand which patients will respond to which treatments. Yeah? Now here we can see a typical nerve fiber, maybe part of the median nerve, yeah? And it's being damaged in the carpal tunnel. And you can see that's a healthy fiber, and this is a damaged fiber. And we know that large fibers are myelinated, aren't they? They have a little myelin sheath, and that can get broken down, maybe because of the person's job, because of their repeated action on a keyboard. The myelin sheath breaks down, or because of some disease process, the myelin sheath breaks down. When we touch the patient's hand, the electrical signal that's generated escapes at that point. Yeah? And this can then be transmitted in unmyelinated fibers, C fibers, which cause pain. So I touch the patient's hand and they feel pain. This explains why peripheral mechanisms can cause pain. Now, if you don't do anything about that, if you walk around like this, if you smoke a lot, if you've got a bad diet, if you drink heavily, then it's going to take a lot longer to get better. If you optimize the treatment with some simple exercise and some simple treatments that we can provide, this can recover more quickly, as we saw in that example with that study where they treated them with some simple manual therapy. Yeah? So I think we need to understand about the mechanisms if we can, but I'm going to broadly classify them into central and peripheral mechanisms. Yeah? The central mechanisms are much harder to deal with and are much less likely to respond to the kinds of treatments that we can provide from hands-on manual therapy and exercise. Yeah? Now, our medical colleagues have a classification process to identify when a nerve is the cause of the pain, neuropathic pain. So they follow this process here. Yeah? Now, that's all well and good, but it doesn't really tell us when we can treat a patient and when we can't. And the classic case are these two here. The top one, you can see this patient's got severe changes, consistent with complex regional pain syndrome. Yeah? It's a very severe form of neuropathic pain, it can be, and this person is much less likely to respond to hands-on manual therapy and exercise. Yeah? Whereas this condition here, this patient has a cervical radiculopathy, bilateral, for different reasons. And we know that those patients, they have nerve pain, but they respond well to hands-on treatment. So if you looked at these two patients, they would be positive on the medical classification for neuropathic pain. But it wouldn't really help us to identify which one we can treat and which we cannot. That's why we developed a classification system, which we published a few years ago, to try to differentiate different groups of nerve pain. So essentially, the ones with the complex regional pain syndrome have really florid changes of the central and peripheral nervous system. And they have all these complex mechanisms. Yeah? Those do not respond well to physical treatments. So we need to identify those and treat them in a different way. Some patients have what we would call a compressive neuropathy. And that may be because they've got a stenosis, a disc prolapse, or a carpal tunnel syndrome where the nerve is compressed. Those patients respond well to hands-on treatment. Yeah? And then there's a third group of patients where there's no distinct damage of the nervous system, it's just sensitized, it's just inflamed. Those are the ones we were seeing some examples of before, where we could test for sensitivity of the nervous system. The nervous system is inflamed, the treatment is to desensitize it. The nervous system is compressed, the treatment is to decompress it. The whole nervous system is overly sensitive, stay away from it, don't touch it, but help to de-amplify those central mechanisms. Yeah? That's in a very simplified way. Yeah? So that's what we need to look for in our patients with nerve pain. Now if the patient's got pain in the elbow, tennis elbow, and we do these tests and all of them are negative, the pain must be musculoskeletal in origin, mustn't it? So musculoskeletal pain is a diagnosis of exclusion. First we must look for these problems. Hopefully we don't find them. So their pain must be musculoskeletal. Yeah? Now the order of testing is quite important. So the group on the left, for some reason isn't working. The group on the left here, neuropathic pain with sensory hypersensitivity, that's the most important group because they don't respond well to hands-on treatment and exercise. So we should look for those first because we don't want to harm them by giving them inappropriate treatment. Yeah, so that's the red group. Now the next one to look for is to see if there's any evidence of compression of the nervous system. Now these groups are not mutually exclusive. They can all coexist. You can have all of them at the same time. Yeah? So then you treat the most important one first. So if they have element of sensory hypersensitivity, we must treat that first. If they do not have that, we look to see if the nerve is compressed. If they do not, we look to see if they have any sensitivity of the nervous system, and so on. Yeah? Does that make sense? So I think it's very important that we try to identify the patient-specific problem.